I'd like to start by introducing our speaker, Julie Morath. Julie is an international consultant in patient safety and healthcare quality leadership. She helps clients create cultures of safety and design reliability into clinical practice and the structures and mechanisms that support patient care. Ms. Morath brings a broad perspective and demonstrated results to her engagements. She is a founding and current member of the Lucian Leap Institute of the National Patient Safety Foundation. She has been an elected member of the Board of Commissions of the Joint Commission. She also currently serves on the Collaborators Board of Directors, as well as governance and advisory boards for several associations and healthcare systems. Ms. Morath founded the Hospital Quality Institute, which supports more than 400 California hospitals and healthcare systems. She was honored to be the inaugural recipient of the John Eisenberg Award for Individual Lifetime Achievement in Patient Safety from the National Quality Forum and the Joint Commission. And in 2018, she received the Bo Biden Humanitarian Award from the Patient Safety Movement Foundation. Thank you so much for being here today, Julie. We're thrilled to have you. And with that, I will pass it over to you to take us through our presentation today.
Thank you, Nicole. And thank you all for having me and for joining me this morning. Transparency is a big subject. And it's a subject I feel very deeply about, which I think you'll hear as we go through the presentation. It's not just a word. It's a whole system and way of being in our care delivery system. So with that, I will launch the conversation. Today, the learning objectives are to define a term precondition and how that relates to transparency, identify at least 2 reasons to embrace transparency in your sphere of practice, identify at least 3 levels of transparency, and to demonstrate an understanding of why being transparent is so difficult. Conflict of interest, I have nothing to disclose. However, I'd like to advise you, my background is a clinician and decades in the C-suite of care delivery organizations. So when I talk about transparency, that perspective always comes into play. I'd like to start by talking to you about a personal experience. And this personal experience is important to me because it underscores the importance of our collective sensibilities around transparency and the effect it has on those who provide care, those who receive care, and those who support the work of care delivery, both internal to an organization and external. In 2000, the Children's Hospitals and Clinics of Minnesota, where I worked, was on the cover of the US News and World Report. This was the best hospitals issue. We were not a best hospital, but we were identified as an organization with potential. And as Yogi Berra would tell us, potential is what you have when you haven't done it yet. And the real interest for previewing the work at Children's was the focus on transparency. So I'd like to just introduce you quickly to Sam Doherty. Sam is the young man on the cover. He was at that time 11 years old. He's with his parents and Dr. Steve Kurachek, his pulmonologist and intensivist. Sam was given a 10-fold dose of a paralytic agent, and the stars lined up correctly, and Sam survived this. There wasn't a procedure room ready, so he was treated in an empty bed in the ICU. A reversal drug was immediately available. Dr. Kurachek was in the environment and could respond immediately. So that was the focus, to begin to talk about when things go wrong, how do you work with and talk with families? And the Dohertys became faculty to work with clinicians throughout the organization and with patient advisory groups. Now, the real story here was the 7-page coverage of what Children's Hospitals was doing. But the one thing that I was very struck by is after this was published, I received letters from families who had lost a loved one, or a loved one was harmed while being cared for in a hospital or clinic setting. The letters were compelling, heart-rending, and the main themes were, I never knew what happened, and I'm living with that burden, or that the hospital had no idea how to talk with me, and it haunts them, and there had to be a better way. So it was a call to continue this work. On the next slide is featured Brock Nelson. Brock was a very courageous CEO of the organization at that time. A 14-year-old boy died of an elusive cancer while in the care of oncology at Children's. He was progressing, he was doing well. Reference lab results signaled a remission, and family and clinicians were celebrating. But the child started declining in his condition, and tensions among clinical staff came up. There was a lot of cross current about what was going on. Finally, an error was detected in reporting from a reference lab. Months were lost in his care, and while chance of survival was low, we took away his chance. The family came in to talk with Brock. They brought a framed picture of their child, and they brought his 2 siblings with them. They sat down with Brock. Brock had not talked to a family before in this manner. Brock had a risk manager and a legal team seated around him. After the meeting, the team, risk and legal, congratulated Brock on his ability to be sympathetic but not disclose anything. The family left. Brock came into my office. I had just recently arrived, and said, "This is the worst meeting I've ever been in my life. We stonewalled this family, and it can't happen again." We went to the board. We brought the family back, and this time it was Brock, the chairman of the board, and myself who met directly with the family at a round table without the distance of a desk between us. And we told them everything we knew and everything we were doing about what happened to their beloved son. We apologized. We reached a settlement for the loss. Because of the chance of survival, the state of Minnesota did not recognize a legal suit, so the family went to media instead. And the settlement included funding for the ongoing care and grief support for his siblings. This meeting ended very emotionally, and immediately we cut through all the process that was taking place in the organization around developing a policy of disclosure and transparency. There were a lot of cross currents, and the organization was kind of split in two. We went to the board, and the board made this statement: legal and risk are important contributors to our work, and we need to always be advised of the limitations and the risks that we're taking on with transparency. But They cannot be the agent of our relationship to those we serve, to our patients and their families. And so the work that we were doing in transparency was launched very visibly. We went to the media, we went to attorneys' offices, we went to the boards of health, of medicine, of pharmacy, of nursing, to let them know our intent. Because how they respond with the shared purpose of keeping people safe could either enable or chill the efforts that we thought were so important to be a safe, reliable, ethical, and compassionate organization. So if you would keep those two stories in mind, I'll reference them as we go forward. A working definition that we can use today for transparency is the free, uninhibited flow of information that is open to the scrutiny of others. This is deceptively simple. It's a word used a lot, but it is a way of organizing and working. Transparency, in my experience, and in talking with colleagues that are like-minded on this topic, is that it's the foundation of disclosure, the basis of trust, a practice value in everything we do, and the most important characteristic of a safe, just, and ethical culture. Transparency, I've come to appreciate as a precondition to giving safe, reliable, ethical, and compassionate care. There are two preconditions that surface. One is respect for people and an ability to embrace the broad sense of diversity, ethnicity, and inclusion. And the second is transparency. Now, this word precondition becomes important to us as we go through this and you think about transparency. A precondition is an ambient characteristic or behavior. It's everywhere within an organization. It's part of the DNA of an organization and of those who work in it. Transparency then becomes an independent of business or budget cycles, of external forces, of strategy, of changes in leadership. As part of a DNA, it's a practice value in everything we do. Transparency is a precondition. In 2015, an important document was published by the Lucian Leap Institute. It was one of 7 that were transforming notions for healthcare. It was entitled Shining a Life. It's readily available. And I think Nicole is going to put the link in the chat so that you can download it for free from their website. This was derived from national roundtables, focus groups, interviews, lit reviews, to understand the state of transparency and the opportunity. Now, we came up with 4 fundamental reasons. Transparency promotes accountability. It promotes trust and ethical behavior. It's a catalyst to improvement. It facilitates patient choice and informed decision-making. Also, it's essential for learning and improvement. And as I mentioned before, the most important characteristic of a safe and reliable culture, that we're exposing risks, vulnerabilities, errors, mistakes, so that we are talking to one another and understanding how to improve and make more resilient the care delivery system. It also reveals variation in outcome and access. And this is particularly important today as we come up against our implicit bias that contributes to health equity issues diversity, and inclusion. Transparency is an authentic expression. And an authentic expression promotes compassion, healing, and psychological safety, where defending, excusing, or being silent has the opposite effect. Now, there are 5 levels of transparency that were identified: with patients and families, with colleagues, with organizations, between organizations, and with the public. In the next set of slides, I'll go through each one by one with some highlights. But know that, yeah, thank you, Nicole, go forward, that there is a spectrum of transparency practices at each level. For instance, at patient family, there's things as routine as informed consent, as complicated as disclosure when things go wrong. And each level will explore some of those practices. There is a belief that these practices are mutually reinforcing, and the thread of understanding transparency deeply and broadly helps pull together an entire care delivery and healthcare system, whether you're in a hospital, without a hospital, outside a hospital, representing patients, families, a payer, an insurer, all part of the system. What is evident, however, is that we lack consistent and reliable processes, education, training, and evaluation to test out these transparency practices and make sure that we are evidence-based in our practices, and we're continually evaluating and improving them. The next slide kind of speaks to me about, we share a vision, a broad purpose with transparency, which represents the main highway. But if you look at all the spurs that come off that and go in different directions, this represents to me the variations we have in implementation. And those variations are confusing. And they set up unintended reactions by persons, organizations, agencies. So we have in front of us the opportunity to reduce variation and understand and practice transparency. So the first level of transparency is with patients and families. The purpose is to promote trust, ethical care, and develop a culture. We want patients and families to present for their care with a sense of relief that they're going to be helped and guided, and not a fear of what's going wrong. In the absence of being able to disclose and talk to families about risk, about error, and about harm, their source of information is generally through the media. And I will show you kind of what that looks like. And of course, the big risk of that is that the sensational, the big cases, begin to take center spotlight, and we lose track of the systematic, the systems, and the opportunities that reside with us. The comprehensive communication and resolution program promoted through this collaborative is an opportunity. It's probably the strongest mechanism we have to begin to align, reduce variation, and become experts at what we do. Transparency and talking with patients is not just a responsibility, but it's a professional skill. And any professional skill needs development, refinement, feedback, and improvement. The other thing is that there needs to be policy and principles to guide this work so that people aren't needing to just make it up. When I go back to that cover on US News and World Report in 2000, there weren't people doing this work. And so we had to make it up, albeit with a lot of thought, a lot of interviews, a lot of interaction, relying heavily on our patients and families to come up with the best we could at that time and continue to improve it. What a gift to have these mechanisms available to individuals and organizations today. The next level is with colleagues. Again, promoting trust and ethical care, advancing learning and improvement, and to embrace this kind of transparency, accepted dimension of professional practice that does not involve blame, shame, judgment, but simply focuses on what do we need to do better. Again, this working with colleagues is not an easy thing. And I would recommend you to the paper that was recently published in the New England Journal of Medicine, authored by Tom Gallagher and colleagues, about talking with patients about other clinician errors. This was a feature back in the story I told you about the young man who died of cancer. There were errors made by pathologists and laboratory scientists. The question is, how do you talk with families without destroying the reputations and the ongoing working with those colleagues that you were dependent upon to do the right thing? And in the absence of feedback, just getting by, there is no opportunity to really improve that work. It's not easy, but it's essential. Within an organization is another level. And I bring that up because this is the context of where care is experienced and delivered, and clinicians are working. And the rest of the system is interaction. The organization can be a unit of a hospital, it can be an entire hospital, it can be an ambulatory practice, it can be an individual small practice. But it requires a culture of respect and psychological safety. And that's a topic for a whole nother talk. Again, these are preconditions, and psychological safety is the outcome for individuals to feel safe that they can talk about things they're concerned about. Policy and procedure guidance is important. This is how we learn to predict and prevent. So a robust reporting system is extremely helpful, but reporting isn't enough. It's wasteful if it's not converted to analytics and information that help inform the users of that reporting to get better at what they do. The other, and again, our collaborative helps advance timely and robust RCAs, root cause analysis. So one of the things that I did early on that shows up in the case studies is I got rid of the term RCA. I saw RCA as an end in itself and a pursuit of a single source of failure. Now, we've gotten a lot smarter since then. So we used event analysis and began to change language to open up the field to be more comfortable that this is not an outside judgment, but it's part of the work that we do. A distinguished team worked with the Joint Commission around RCA, and while they weren't willing to give up the term root cause analysis, they put a squared on it. So it's root cause analysis and action. And that closes an accountability loop, that action requires disclosure, change, lessons learned. Across organizations, we begin to see a little more difficulty. There are all kinds of things that come into play. Market, competitive edge, reputation. No one wants to be known as someone who's harming patients. But we need to recognize that what happens in Boston can and will happen in Seattle. And unless we are communicating those lessons across our organizations, we're missing the opportunity to mitigate before harm occurs. We're finding this even in neighboring organizations. But if our culture, broad now, begins to embrace transparency as a precondition of how we operate, this becomes absolutely essential and accepted. And it's collaboratives like this that are help paving the way. And it's providing the curriculum tools and methods so that we can become better aligned. And this just isn't inside of health core organizations. We can do better with our PSOs. The wealth of information they have about things going wrong, to convert that into alerts and lessons learned. We also have the opportunity across organizations for alignment and collaboration when possible. And I believe everything is possible. It may not be as timely as we'd want, but with our legal, regulatory, insurance payer organizations, and I would add media to this as well. And finally, with the public. This is the kind of ultimate accountability for the work of the entire healthcare system. In California, we work to create website posting of performance information of all our hospitals so that people could see what performance looked like. Is it perfect? No. Is it improving? Yes. And if it's not, what are we doing about it? It's a conversation starter with those that we serve, that they can begin to have a window into the clinical enterprise. This other piece of transparency with the public helps generate a research agenda. And a national research agenda is going to be very important for us in this work of transparency as a precondition for a safer, more resilient healthcare system for the public. This is not work without peril. This is difficult. This is difficult work. If you just take the word transparency and throw it around, it doesn't seem that much of a lift. But when you begin to look at what it takes, it's a lot. Why is it so difficult? Well, in healthcare, we have a cultural response to failure in healthcare. It's getting less, but society still wants heads to roll when things go wrong. Secrecy is built into our system. picture with Brock was do ask, do tell. Begin to open up the field so that we know, we understand, and where to put our attention. It's culturally, strategically, and technically difficult. This isn't about sitting down and pouring out everything you know and are thinking about to somebody else. This requires discipline and training and resolve. The other thing that makes it difficult is that we're human. When things go wrong, the brakes come off our cognitive biases. You know, there's outcome bias, severity bias, confirmation bias, the whole field of human factors. And when we're under stress, and when we're surprised, and when we feel we've failed someone, these biases rise up to provide barriers to us doing our best. So the more we understand this, the more we understand our human nature. Following this, of course, is fear of failure, judgment, shame, ridicule, and negative consequences. The other thing that makes this difficult is measurement and performance information, including transparency with others, is often weaponized. Now, that's a violent kind of term, but it feels that way. So information, if we're not all aligned and on the same page, can be used for purposes that does not serve improvement and engagement. That's why we need this collaborative. That's why we need these discussions. That's why we need a very deep look. It's difficult because people are at risk. Patients and families, absolutely, but also providers and caregivers. They're concerned about reputation, license to practice their profession, or even criminal charges. Now, one of the works we did early on, that's in that US News and World Report, is we sat down with the health department and asked if they would give relief to our staff that were in the rubble of an event when it happens, if they were actively engaged in analyzing what happened and making improvements, and that we openly reported what happened and what we were doing about it and what the lessons learned to the health department. And we reached an agreement that we can live together and partner on what's so important here. You know, if you go back to the Betsy Lehman case, with multiple nurses had their licenses at risk, yet so many people were involved. These are the kinds of things that we have the ability to work through and make substantive changes. A word about peril, and that is transparency in the face of failure. Now, that's outlined on this next slide. So failure includes planned action not completed, the wrong plan, errors, mistakes, and lapses leading to unattended events, omissions. The other thing that happens is that human tendencies become magnified when there's harm. Everyone wants to attribute, and it's very hard not to, because then you're relieved and can move on, but you can't really, because the same vulnerabilities, behaviors, and risks are still working, if you remember the Swiss cheese model, to lay in wait for another human being. It's very difficult, and we still have blame, shame, and guilt. And as Lucian Leap reminds us on a regular basis, it's that blame that's probably the greatest deterrent to making improvement in patient safety, because it prevents transparency and learning. And I mentioned cognitive biases before. Thinking about system is still not a norm. I'm still surprised this many years later that the first impulse is to go to a person. So words to work by that we established are what happened, not who did it, and others that take away the connotation of a investigative report, but rather reframing an analytic task when there's failure. Honesty and truth-telling to disclose is an ethical obligation that's well accepted. However, we don't know how to do it all that well. And one of the things that isn't talked about a lot, but it has been on my radar screen, is that limited transparency or situational dependency, transparency, deciding when to be transparent, when not to be, and how transparent to be. And it changes all the time, and is person dependent or situation dependent, begins to promote distrust, it damages relationships. It increases litigation. There are missed opportunities to learn and improve, and it leaves emotional damage for those that are involved in these kinds of interactions. Now, one of the things that was very concerning and is to most healthcare organizations and individuals is the question of litigation in the face of failure. And one of the things that studies are finding is that litigation actually is decreased when there is open, honest, and aligned communication and the opportunity to make amends and to compensate, and most importantly, to improve. There are some references I'd refer you to that I've found extremely helpful that speaks about transparency and learning from failure. Amy Edmondson is well known for her work in this area. This is a copy of one of the Harvard Business Review covers. She's also published books in this area. The work of Tom Gallagher and his peers, I've shown you earlier, introduced you to the latest paper, are extremely helpful. Black box thinking is not what you'd expect, but it begins to explore why some people never learn and others learn from mistake making and failures. I think that is one of the things that is confronting us in medicine and healthcare, is how do we become those folks who do learn and become more resilient. Ian Hagen is the director at the Eastern European School of Management and Technology, who studies managing errors in high consequence organizations. And his book covers high consequence organizations. There probably is not an organization with as much complexity and high consequence as healthcare, but there are many organizations: nuclear energy, military, aviation, food safety. that when things go wrong, lives are at stake. And there's a lot to learn from other other organizations. Although I don't promote a one-to-one translation, I think we learn from those and then see how does that fit. The next slide is, we're really worried about performance being out there in the media, but this is like a montage of what's already out there. It's already there. And so as our organizations begin to think deeply, I think the one thing we can do is find a coherent and comprehensive way to talk with consumers and patients about what are the risks. And I would go further, channeling some of my colleagues in the patient advocacy field, that this isn't about us figuring it out. It's about co-creating with them what are the best messages, mechanisms, and delivery systems to get information out there. Otherwise, today, our public and our patients are making assumptions about what they're reading in the media, and also what's posted on government and other websites that have 18 months to 2 years lag. Now it's getting better, but it isn't the performance that they experience today. So my deal has always been, and was back in the day, is that we can't continue to play chicken with one another. We can step forward and we can begin to change the conversation. So consider this. And this I see as a potential of CRP. If you look at all these pieces, we can put it together into a whole pie that is coherent and reliable and contributing to greater care. And I think we've covered most of this. So let's start with, the patient and family is always first. That's who we're doing this for, is for the public, both in the public health model, in the acute care model, post-acute care, across the continuum, across the journeys that patients make. The second is, could we imagine a common definition in language? Common definition in language. If you believe that language shapes culture, this is a big opportunity to begin to look at how do we want to talk about this? Not the percussionistic, bombastic, throwing back and forth of ideas, concepts, and disagreements, but rather leaning into and learning to talk with one another, with the endpoint always clearly in front. How can we align all parts of the system? This is a start. I think it's a great start. And I applaud the coalition for collaborative for putting all the work and patience and connections that they have into this. And I think we can use this as a springboard to continue the alignment, and everyone within your own sphere of control and influence can begin to do the same. Standard evidence-based education and training would be great. I think everyone's doing the best they can, but we could save money. We could improve the conversation. We could help with the development of all our professionals, regardless of where in the system or how in the system they work, to work together and to work with those served. We also have the opportunity to influence robust and reliable policy and process when there is harm, And we do have in programs such as Candor ways to do that. And it's a matter of endorsement and spread. And then I think a really interesting area is to actively engage in the ongoing inquiry and discovery into practices of transparency and actually build implementation evidence so that we can speak with some authority about what works and how to help people get there. So to wrap up my comments, my belief that is shared by many is transparency is required to transform the healthcare experience. Transparency is a skill that requires policy guidance, education, and coaching. Transparency can create pathways for the workforce to find and sustain joy and meaning in their job. When people carry secrets and guilt, it is so painful. Working in organizations, my office became a steady stream of folks who were carrying grief for their involvement in an event that harmed a patient 10 years previously, but there was never a mechanism to talk about it. Things like Schwartz rounds and other other vehicles are coming to help our workforce to do what they need to. And especially in these times of pandemic, we really have to step back and begin to think about how to best care. Transparency is also a basis to mitigate the asymmetry that exists in information and align our actions. And finally, it's the right thing to do for ethical healthcare. I'd like to leave you with some final thoughts. This is hard work and it requires reflection. And maybe these questions you could take away and use. This is not a spot improvement. This is not a project. This is not a transaction. This is really all-in work. And when you commit to all-in work, there are some things to think about. So I would invite you to consider some of these questions. I regularly review this to keep my head on about what it is that I want to do, how I can contribute, and what I believe to be the most promising future. How would you expect and want to be treated? Do you talk about transparency as a value with others in healthcare? Not just a communication piece, but transparency as we've talked about it today. What are your own limits of intolerance? Where do you get anxious? What gets evoked in you when we talk about transparency? And that usually leads up to what is the worst imaginable consequence of being transparent in your practice? And what do you need to better understand the role and promise of transparency as guideposts for future research? And is this the time? And if not now, when? So I thank you for your attention and for participating. And Nicole, I think I have time for final comments or questions.
Yes, thank you so much, Julie, for such a wonderful presentation. We'd love to open it up to questions that anyone might have. Feel free to turn on your video and unmute yourself and ask your question directly. You can also enter any questions that you have into the chat box and we'll keep an eye on that. And we'll give people a moment to think of their questions. But thank you so much, Julie, for that great presentation today.
Oh, it's my pleasure.
So Julie, this is Carol Hemmelgarn.
Hi, Carol.
Hi, and I want to make a comment on your co-creation, and in particular, making sure patients are part of it. There's about 5 of us that have just submitted a paper to BMJ, and hoping it'll be accepted. But it's about how harm has been defined from the medical community and not been defined on how patients and families would define harm. So I just want to reiterate your point of, as we're going through with language and creating definitions, that you do have to have the patient and family voice as part of it, because we may define things differently than medicine and healthcare does. So I appreciate you saying that, and I think that's a spot on comment.
Thank you, Carol. I have learned a lot from families, and I'm very supportive of the work you do, and I think I'd love to see your article published. It's important voice.
Julie, it's Tom Gallagher. A wonderful presentation. Thank you so much. I'm sure you've had the same experience that I have had, which is talking with healthcare workers at organizations that have a commitment to transparency and have really been open with a patient and family after a harm event and have had second thoughts. They got sort of pilloried for what happened in the news media. The organizational blowback has been considerable, and they sort of come to me with the question, well, we think this is in theory the right thing to do, but it feels awfully painful to us to actually go through that journey. What sorts of advice do you give to folks who have had rough experiences being open and are trying to weigh the was it really worth it question?
Yeah. Well, that's a day-long discussion, Tom. I think this work has a lot of cross-current of thought and feeling. And there has to be a resolve and a staying the course. I've found that you cannot blink. If you believe in this and you stay the course with it, it will unfold. I also think that a lot of preliminary spade work is often not done, so that we're working with the family with disclosure without the context of purpose for the rest of the organization, for the media, and for others. I found it extremely helpful for organization leaders to sit down with editorial boards in their hometowns, to talk with civic leaders, and most importantly, to have fireside chats. I find fireside chats and cups of coffee often much more helpful than lectures and other media, to talk with people about what you genuinely believe in, where you're heading with all this, and what the opportunities are for the future, so that the vision becomes stronger than the pull to stay status quo.
That's great. Thanks for that thoughtful response.
There's not a paucity of wear and tear when you make changes of this magnitude in culture. You've got your foot in many different fault lines.
I have an enormous amount of respect for our colleagues at the VAs, because I think in some respects they have a special challenge. They're really open and transparent, but you know, the problems at the VAs can become political footballs and lead to congressional hearings, and there's not the celebration of the transparency. There's really just the focus on the problems.
Right.
And so, you know, I think every organization struggles with this, but I think our friends at the VA who have hung in there despite getting beaten up a little bit around transparency, it's especially impressive.
Yeah, you know, in the very early days, I had the opportunity to work closely with Ken Ken Kaiser, and it takes a toll. But if you have the resolve and the vision of what it can be, you go through it.
If there's not another question, I'll just keep going for one other second. Some organizations, I've wondered whether we'll get to a time when organizations compete around transparency, and try to make the case to the public that you want to come to our organization because we're particularly open. I still haven't figured out how you message that in a way that doesn't sound to the public like, well, our care is not of great quality, but if there's a problem, we'll sure let you know about it.
Yeah.
And I haven't seen organizations yet that have really been willing to lead with transparency as a primary element of their marketing to the public. But you may be aware of examples where that has been something an organization has publicly embraced as a differentiator relative to competitors in the market.
Well, I think there are some organizations that have leveraged their websites in terms of, you ask and we'll tell you, and not only that, but here's where we are and what we're doing. There's been a lot of constraint about, in fact, encouragement not to use transparency information in performance as a marketing tool, but rather to help informed decision making. I think our consumer groups and patient advocacy groups, people like Carol, can really help inform how we might want to think about that. I just, in the market I'm in, I look at a place like Dignity. They have the message wrapped around compassion. That part of demonstration of compassion is listening, talking to you, and letting you know. So that may be how we could start to frame that conversation.